I need a mic. Good, okay. All right, so hi everyone. Thrilled to see everyone, and I know that there's some people online as well. So I'm continuing that work and also kind of broadening my work within the realm of cardiovascular disease, specifically focused on women in my research program. And just with respect to my advocacy, so I have close family members that have cardiovascular disease, female family members, and about 6 months before I started my PhD, my mother actually underwent quadruple bypass surgery. So very near and dear to my heart, and something that I'm very passionate about. So just some quick notes about the Canadian Women's Heart Health Centre, CWHHC. So this presentation was developed by the Canadian Women's Heart Health Centre, and the Women's Heart Health Centre is committed to ensuring that everyone, not just women, but everyone, becomes aware of how heart disease and its risks impact women. With respect to advocacy, so this is a large part of what the Canadian Women's Heart Health Alliance, as part of the Canadian Women's Heart Health Centre, does. And so it's all about kind of transforming public attitudes and making sure people are educated about women's heart health and getting the information they need in order to make more informed decisions about their own health. I do have to, I do have a disclaimer, and so I'm going to read this because I think it's really important. Any information that's provided in this presentation by me specifically should not be considered medical advice. It's not intended as a substitute for medical professional help, advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified medical healthcare provider with respect to anything that has to do with your medical care. And of course, the views and testimonials and anything you hear during this presentation by me or anyone else in this, here today or online, they're my opinions, the opinions of those individuals, and not of the University of Ottawa Heart Institute. And the University of Ottawa Heart Institute does not guarantee the accuracy or appropriateness of the opinions or advice offered by individuals here today. So just needed to get that part over with. So there are about 6 objectives, learning objectives for today, and I hope by the end of the session you'll be able to kind of describe what heart disease is. You may know this already. Describe how heart disease is different in women, including signs and symptoms and causes. Explain the risks for heart disease. Describe how you can take heart health action. Lots of tips actually for talking to your healthcare provider, and then I'll end by talking about some key messages, reiterating some things that we talked about. So the first learning objective, oh, and I should say that there are going to be some true and false questions throughout, and some kind of open-ended questions, so feel free to chime in, and for individuals online, you can put it in the chat if you'd like. Hopefully that this is interactive. So what is cardiovascular disease? It's a really broad umbrella term. It's a general term for conditions that affect both the heart and the blood vessels. And so this includes heart disease, so coronary artery disease, things like heart rhythm disorders like atrial fibrillation, which is something that I studied for my PhD. And of course, these diseases can lead to heart attack and even death. And maybe this is not surprising to you, maybe it is, heart disease is the leading cause of death for women worldwide. So start things off really early, really quickly here, test your knowledge. Heart disease is on the rise and is the leading cause of death for women worldwide. Yes, exactly. So a lot of people don't actually know that. We'll get into some facts, important facts on the next slide. But there's a reason why this quiz was right after the thing that I said, because a lot of people think, oh, it must be breast cancer. But no, it's actually heart disease. So some kind of sobering facts: heart disease claims the lives of 1 in 3 women worldwide, and 1 Canadian woman dies from heart disease every 20 minutes. Heart disease is a leading cause of premature death in Canadian women. And I'll talk about what premature death means in the next slide when we talk about increasing rates of heart disease. Heart disease kills 3 times as many women as breast cancer. And I think that is sometimes things that we don't think about, because we typically, when we think about women's health, think about bikini medicine. So things that are covered by a bikini is what we think about when we think about women's health. We need to change that perspective. Heart events are increasing among women aged 35 to 55 years of age, so that's typically premenopausal years. And that's very, very concerning because that is what is considered premature heart disease. 1/3 of women who have heart disease try to resume their diagnosis lifestyles, but again, heart disease is not cured by, let's say, surgical intervention. If you undergo quadruple bypass surgery, it doesn't mean you no longer have heart disease. It just means you have undergone a surgical intervention to improve your lifestyle. It's an ongoing disease. It's a lifelong disease, and so it's really important to be aware of that. So one thing that I think people don't think about is, are women's hearts really that different? So if you were to look at a physiology textbook, let's say, open it up, you wouldn't see here's a man's heart, here's a woman's heart, because they look structurally very similar, but there are important differences. So we'll talk about how heart disease may be different in women, what might be different with respect to the signs and symptoms, and how the causes of heart disease may be different in women. So there are female predominant heart disease conditions and female specific conditions that a lot of people don't know about. So when it comes to kind of the structure of the heart, women's hearts tend to be smaller than men's hearts. Women's hearts beat faster. Women's coronary arteries are smaller. So these are the vessels that bring oxygen and nutrients to the heart. Women's plaque buildup is different. And so women tend to have, we'll talk about this a little bit, but women tend to have more issues with respect to their microvasculature, so the smaller vessels. Men tend to have more issues with respect to the big vessels, or the larger vessels, so the coronary artery vessels. And women's hearts are affected by hormonal changes. So we have menopause, pregnancy, lots of hormonal changes and fluctuations there that can affect how our heart reacts, and our not just our heart, but our entire vasculature, so our vessels. So there are some risk factors that are unique to women, as I had pointed out before. So common types of heart disease, so both men and women have coronary artery disease, valvular heart disease, so this is when the valves don't work as they should. Sometimes you can be born with those issues, and sometimes they can be acquired due to any number of issues. I talked about arrhythmia, so this is an abnormal heartbeat. I studied atrial fibrillation, which is when the atria quiver and beat very quickly and erratically. But women are more likely to have certain conditions. I don't know if you've ever heard of SCAD, but this is spontaneous coronary artery dissection. And this more often, first of all, let me preface anything I say with this is very rare. So this is when you have a tear in the coronary artery, in a coronary artery. Extremely rare condition, but it is far more common in women. And it happens more often than not. 70% of these cases happen in the postpartum period. So I believe within a week after delivery. We don't know why this happens. This also happens in pregnancy. And so we think that it has something to do with the stress and strain of pregnancy. Why some women have SCAD, other women don't, we're still studying this. We're not really sure. Microvascular dysfunction, I talked about this before. Women tend to have microvascular dysfunction, so the small vessels don't work as well as they should. And that seems to be more of a problem with women, especially in estrogen deficient women. And so stands to reason that we see this more often in women in the menopausal years, but also in younger women who have some estrogen deficiency. And of course, I'm picking all of the pregnancy-related ones because, you know, I'm studying women's health and I'm in the Department of Obstetrics and Gynecology, so I have to represent. But peripartum cardiomyopathy, you know, also is something that happens that a lot of people don't know about. The heart gets weakened for some reason. And again, why this happens in some women and not others, we are not sure. I studied hypertension in pregnancy. Some women without risk factors, marathon runners, get these conditions. Other people with risk factors for heart disease do not get these conditions. So there's a lot we still don't know and a lot we need to study. So all of this to say, when it comes to heart disease, women are understudied, women are underdiagnosed, undertreated, undersupported, and underaware. And why? Why did this happen? Well, why are 2/3 of the studies on cardiovascular disease done on men? Safety concerns, all sorts of safety concerns with respect to people not only who are pregnant, but who might become pregnant. So there is, you know, this precautionary principle. Oh, if you might become pregnant, then we couldn't possibly include you in studies. But there's a consequence to that. Hormone fluctuations, we talked about that as well. For so long, one of the major reasons why people didn't want to study women is because we have menstrual cycles. Oh my goodness, that's going to throw off our results. We couldn't possibly study women. And so the conclusion was, well, that's just too complicated. So we'll just take everything from men and apply it to women. That is illogical. It doesn't make any sense. If we're more complicated, that's more reason to study us specifically. And of course, lack of participation. Lots of women don't know that there are studies available that they can participate in. There are barriers to getting into those studies because, again, lots of exclusion criteria around women of reproductive age. But also, women tend to be caregivers and maybe don't have the time to participate. And so there are studies that are looking at how do we get women involved in research? How can we make this more how can we make research more accessible to women? Women are slow to identify the signs and symptoms of heart disease. And we'll talk a little bit about specific signs and symptoms that might be different for men compared to women. Sometimes these are referred to as atypical. I don't like using that word because women are 51% of the population. You know, if it happens more in women, you know, that's the majority. So how is that atypical? But again, if your reference is always men, then yes, we would call that atypical. Women often delay seeking help because, oh, you know, I'm too busy or I have to take care of my kids. How can I go to the hospital? I need to pick up my child from school. I don't want to bother anyone. I don't want, it's embarrassing because I'm overreacting. This tends to be the sentiment that women have compared to men. But if you suspect there's a problem, every minute counts. You want to minimize the damage. So if you think there's an issue, it really is important to seek help. Another test your knowledge. Heart attack symptoms can present differently for women compared to men. We're all saying true. I don't know if anyone's replying online, but you can reply online if you want as well. Yes, absolutely true. Can you name some signs and symptoms a woman could be showing when having a heart attack? Go ahead. Jaw pain?
Tightness around the chest.
Tightness?
Is that pain as well?
Yep.
Shoulders.
You guys are so good. So good. Yeah, yeah, absolutely. So chest pain, pressure, discomfort, sharp and or burning chest pain, as somebody had said, unusual fatigue and weakness. And again, taken alone, some of these, you may be able to explain them. And so this is why these non-specific symptoms can be very, very tricky. But if, for example, you cannot explain your fatigue and weakness, that may be a sign you need to get checked out immediately. Shortness of breath. If you're going up 5 flights of stairs and you have some shortness of breath, that's different than just standing up, getting out of bed and having severe shortness of breath, right? So, think all of these have to be thought about in context. Now, these are things that you may not have realized, but upper abdominal pain, abnormal and excessive sweating, nausea, trouble sleeping, interestingly enough. Some women report this. Palpitations, jaw pain, somebody mentioned that, and back, shoulder, or right arm pain. So typically when we think about a heart attack, we see the Hollywood heart attack. Clutch your arm, slump over. Some women have a Hollywood heart attack, but that may not be most women. That may not be what a heart attack looks like in a woman compared to a man. So let's talk about undertreatment. We know, based on some of the things that I mentioned before, that the risk of heart disease in women is often underestimated. And again, maybe this is not surprising based on what I've said, but this is due to differences in signs and symptoms, as I alluded to before, lack of awareness in the general public that, again, heart disease is the #1 killer of women worldwide. And there are knowledge gaps, and not just knowledge gaps for women generally, or the general public more broadly, but for healthcare providers as well. I had, just as a personal anecdote, a family physician on my doctoral committee, and he did not know that there was an increased risk in heart disease in people who had preeclampsia and other high blood pressure conditions in pregnancy. Was not taught that in medical school, did not know that. So again, this is not just a general public issue. This is a clinician, lack of knowledge among clinicians as well. So after heart disease diagnosis, women are 50% less likely to participate in cardiac rehabilitation. And the studies on this are staggering. Despite similar benefits for both men and women with respect to cardiac rehabilitation, women are referred less than men. There's no other reason than bias. No other reason for that to happen. Women are simply referred less than men. Similar benefits. And not only that, but when women go, they tend to drop out because they have other commitments. They just can't maintain the schedule. They tend, especially younger women with smaller children, they just don't make it a priority. And again, I touched on these reasons why. And there are lots of studies that are trying to address this. Virtual options for women, for example, have shown a lot of promise. And just making women aware that, this is so beneficial, and if we can get, a support system around women, or, bring your kids and somebody will look after them at rehab, so that you can participate. So removing those barriers, really, really important. Women are under aware, not just women, but the general public and everyone really, there's this under awareness. And it's really important to consider, I have 2 words here, perceived and actual risk. And there's some really interesting studies that have been done, kind of shocking studies, that there's a disconnect between having important risk factors, let's say high blood pressure and diabetes. These are especially strong risk factors for cardiovascular disease in women compared to men. Diabetes is really dangerous in women compared to men. It's dangerous in both. It's a risk factor for cardiovascular disease, but it's especially dangerous for women with respect to increasing cardiovascular disease risk. So is high blood pressure. And this is why people like me study high blood pressure in pregnancy. And so there's a disconnect. There was a study that was done, a survey, and women who had two major risk factors for cardiovascular disease actually perceived, I think 60% of those individuals perceived their risk of cardiovascular disease to be low, despite having or being treated for high blood pressure, let's say, and diabetes. They perceive their risk to be low, which is really shocking. So there is quite a disconnect here. So let's move right on to learning objective 3. What are the risk factors for heart disease? I talked about these. It's pretty hard not to talk about these intermittently, as we go through. But it's important to know what you can do, because this is all dire. Oh my goodness, if you have these risk factors, what are you going to do? Well, there actually is a lot that you can do. First is being aware. If you're aware of the risks, then you can obviously personalize them. Okay, it's all about, okay, what is my perceived risk? I have these risk factors, but I need to internalize them. I need to personalize them and say, I need to do something about this to change my trajectory. And when you personalize it, you can then take important actions to lower your risk. And of course, as a consequence of that, you will have improved cardiovascular health. But it's important to take kind of this life course approach. Of course, we can't go back in time, but it's important to understand this kind of life course approach and action to what we can do. And so, everyone says this, but it is really important as an adolescent, as a child, it's really important to initiate those good habits. Because if you initiate them early, if you encourage, and not everyone has to be a star sports player, that's not at all realistic for a lot of people, but encourage healthy habits, encourage walking and whatever to remain active. And stress management is really, really important. I think often we forget about the psychosocial aspects and how important that is. There is a heart condition that is very, very much linked to stress. SCAD also as well is linked to stress. Very highly stressful situations. It can affect your heart. So it's really important to have these coping mechanisms and these ways to deal with stress. And starting young is a really important first step. Of course, it's important to know your family history. I know my family history. I have to be especially careful, right? I have to be on top of my numbers. I have to know my numbers. I have to be active. I have to eat well. And so, really important to be cognizant of that and take that to heart and personalize that. This wasn't mentioned previously, but certain ovarian conditions, polycystic ovary or ovarian syndrome, that is associated with increased risk of cardiovascular disease. So many people don't know that, but it is. And so it's important to first educate yourself and ensure that you find the right physicians and not just physicians, but healthcare professionals that can help you deal with that and help modify your lifestyle to give yourself the best chance at prevention. I've already talked about pregnancy complications. Again, so many, not only cardiovascular diseases, but risk factors are associated with pregnancy. These are female-specific conditions that we need to be cognizant of. And post-menopause is so important. You may have heard that estrogen is cardioprotective. There's been a lot of controversy with respect to the use of hormone replacement therapy. So, but I think the consensus is that the estrogen that we have inside us premenopausal is cardioprotective, because when menopause hits, our estrogen levels go down and we start to see increased risks of cardiovascular disease and so on. When even if it's not natural, so premature menopause, if it's surgically induced, so you have a radical hysterectomy where the ovaries are removed, that can start menopause, and that is a risk factor for cardiovascular disease. And prevention is really, really key. We talk about primary and secondary prevention, but I like to talk about primordial prevention, which is let's stop the risk factors. Let's eliminate the risk factors. So way upstream. So it's important to go as upstream as possible. Primary prevention is all about let's prevent the condition from occurring. So primordial prevention is let's stop the risk factors. We don't want chronic hypertension. We don't want diabetes. Primary prevention is, okay, we have those risk factors, but we don't want cardiovascular disease. So we're going to manage those things. Secondary prevention is screening. Whenever you hear secondary prevention, you should think screening. So, know your numbers, get your cholesterol checked, get your blood pressure checked, check your blood glucose. So these are all different prevention factors. Tertiary prevention, even more downstream, is cardiac rehabilitation. You already have the disease, you've undergone an intervention. We're going to try and make sure that your quality of life remains as good as possible moving forward. Okay, another quote. Smoking commercial tobacco and vaping is a risk factor for heart disease. True, of course. I'm pretty sure everyone knows about commercial tobacco. Vaping is not good for you. Vaping is not good for you. There study after study after study come out that say that it can really affect your vasculature. So it's not a benign behavior. And of course, when you're damaging your vasculature, so it's the vessels in your body, that's a risk factor for cardiovascular disease. So it's not a benign thing, people, I think, aren't necessarily aware of that. What are some of the risks for heart disease women should be aware of? So we have non-modifiable and modifiable. What are some non-modifiable risk factors? Things you can't do anything about.
Like family history.
Absolutely, you can't do anything about that. What else can you not do anything about that? Everyone has. Aging. I had a colleague who said, whatever, oh, I hurt my back. She said, Amy, it's an aging issue. I said, yes, it's an aging issue. Everything is an aging issue. Aging is a risk factor for everything. So absolutely. So things like age, biological sex, men, well, again, gender and sex are not the same, but we'll say biological males are not at risk for preeclampsia. That makes no sense, right? So certain conditions, right? Family history, as you pointed out, and ethnicity. I want to be very clear with respect to ethnicity, race and ethnicity. We should not interpret these things as biological. And so, there may be some genetic component to it, but these are not genetic or biological things. We have to think about the social determinants. We have to think about the factors that drive those disparities. This is something that I study, intersectionality and social determinants of health. And so just be careful whenever you hear, oh, if you are a minoritized population, you're at increased risk for cardiovascular disease. Think about why that might happen, right? Think about the reasons why. It's not a biological thing necessarily. The good news is that, and again, people throw around this 80% number, that's been contested, but a substantial portion of heart disease is preventable, and it can be changed. You can change your trajectory. Monitor your high blood pressure, or please do not have high blood pressure. Monitor your blood pressure. Monitor it. You can go to the pharmacy and get it checked. You can buy monitors. Please get them validated. Just make sure that you're verifying that they are measuring what they actually should be measuring. Again, I harp on high blood pressure because it's so important. Get it treated as quickly as you can if you have high blood pressure. It is terrible for your vasculature. So it's terrible for your vessels. High cholesterol, same thing. Diabetes, again, smoking, commercial tobacco, vaping, avoid that. Psychosocial factors, I talked about that as well. Stress management, and overweight and obesity, of course. Know your numbers. And of course, and if you feel that there's a problem, insist that it gets checked out. This is something that I think is so important because often we think, oh, there's a linear trajectory here. So if I have high blood pressure, and diabetes, then, oh, maybe I'm at 2 times higher risk. No, you're at 4 times higher risk. This is not a linear relationship. This is more like an exponential relationship, right? If you have 3 risk factors, For cardiovascular disease, you're at 10 times the risk. So something to keep in mind. I think this is a really good visual representation of that. So popping right into learning objective 4. Again, lots of statistics and such, but how can you take heart health action? What can you do? Well, first remember that it's never too late. Never, ever, ever too late. If you have risk factors, take action to manage them. And of course, it's like, you don't run a marathon after training for one day. Why would you think that you would change your lifestyle behavior in a day? Small steps really make a difference. And of course, you have to reward your success. And that doesn't mean rewarding in a negative way, like overeating or something like that. But just make sure that you're rewarding yourself, because it's really important to do that in order to maintain that trajectory. I'm not going to go over all of these, but these are some really good tips for healthy eating. One of the simplest things you can do, obviously, is plan healthy snacks, right? If you meal prep and have everything ready, if you have cut up fruit in the fridge, then that's so easy. And you might think, oh, well, it's easy to open a bag of chips, but it's even easier to just take a lid off of a container, right? And things like, I think we all know these, like eat fish and legumes. I'm a vegetarian. I eat so many beans and chickpeas. It's insane to go through so many, but they're so good. And listen to your body. If you're not hungry, don't eat. And sometimes we have to, myself included, have to remind myself of that, especially when we get stressed and when we're bored. Just, if you're not hungry, don't eat. It's really as simple as that. Top 10 tips for exercise. Again, not going to go through all of these, but I think these are some really good, tips. Walking, I think, is underrated. I walk a lot. I go through shoes every 2 months. I walk a lot. So I think that is an underrated thing that we can do for our heart health. Park far away. Walk a little bit if it's safe to do so, or further away than you normally would. It's just these small habits that we can do. Go for a nature walk. Nature, one of the best things you can do is get outside, and we have beautiful pathways and parks around here. And if you're not allergic, the smells from the blooms are just gorgeous. So that's one thing that you could do. I think is so important. And move every day. Find a way to move. It doesn't have to be, you don't have to do an hour workout every day, but find a way to get out there and move every day. Ooh, emotional health. I think, again, as I mentioned previously, this is something that we tend to forget. It's something that we tend not to focus on or tend to kind of brush aside. But it really is important to consider all of these factors. One of the first thing listed here is deep breathing. It is actually amazing how that can affect your heart rate. It can actually lower your heart rate. I know that some people, when they're preparing for large presentations, they do deep breathing exercises, and it actually really helps calm you down. So there's method to the so-called madness. One of the things that I think, number 9, I think is so important as well. We always think, oh, I should have done this. I should have done it. Oh, should. No. It's all about changing your perspective. And of course, if this is an issue, and you need help in this regard, we have medical professionals that you can speak to about this that will certainly help you out with this. And it is so important. Again, stress. Major stress is a risk factor for heart conditions, and chronic stress is so bad for your vessels. And again, we tend not to think about these things. And sleep. There have been books written on how good sleep is. Sleep is so important. So lots of things to consider. Stress. Again, I think the emotional and the stress kind of overlap a little bit. Again, lots of tips here. I'm not going to go over them specifically, but one of the things that I, especially now these days, that I had to do, don't read the news. I actually had a friend during certain times. I would say, you need to tell me what I need to know. I can't watch the news. So I had a friend filter, right? Because sometimes it can be really, really stressful. And so if you avoid exposure, sometimes you can't, but to the best of your ability, if you can avoid that exposure, it helps tremendously. So keep that in mind. And take a break. Oh my goodness, we're so busy all the time. You're allowed to take a break. You know, as you know, I'm in a world of academia where we don't even negotiate holidays because people don't take holidays, but we need to take a holiday. We need to break. It's so important, and try to not think about work when you're not at work to the best of your ability, if you can. Okay, we're at learning objective 5 of 6, we're almost there. Talking with healthcare providers. So there are so many things, really great tips out there that I think are so important. The first thing is preparing for your visit. Lots of people think, oh, I don't want to take a list. That seems, no, take a list, write it down. I do, I take a list with me. You know, when you have a physical, oh, I just want to ask about this. I want to, you know, write it down, because who knows, but you know, white coat hypertension is a thing. We get stressed sometimes when we go to, white coat hypertension is when you're in a doctor's office, your blood pressure tends to go up, right? Not everyone experiences that, but that's the thing, white coat hypertension. And so sometimes we can forget things, walk out and go, oh, I forgot to ask. If it's on a list, you will not forget. Know your medicines. Some people are on a variety of different types of medications. And the assumption is, I think sometimes, that, oh, this physician knows what this physician knows. No, they do not. We should have a linked healthcare electronic medical record system. We don't. Some systems are integrated depending on which hospital you go to. Know your medications. I know people who, well, you know, older family members who would take their pills in a bag, set them down and say, this is what I'm on, because they didn't want to forget, right? 3-question approach, really important. What is the problem? Why am I at this doctor's appointment? What's the problem? What do I need to do? So an action, what do I need to do to address this? Do I need to do anything at all? Is it, you know, is it something that, you know, medication can handle or whatever, or a lifestyle intervention, lifestyle changes, and why? Because if you don't know the why, or if you don't understand the why, or why it's important to make those changes, then you're less likely to do that. And of course, if you have that paper and you have things written down, take notes. Something also that is helpful is take someone with you. Perfectly acceptable. You're allowed to take someone to a medical appointment with you, and this can really help. Ask for definitions. If you don't understand what something means, ask. No one's stupid in this situation. I ask for definitions all the time, right? I mean, if you don't know what it means, you ask. Recap. This is what I think a lot of people do at the end of a meeting, and so why not do this at the end of a physician or health professional appointment if you're going to see a nutritionist or whatever. It's really good to recap. So here's what I heard you say. Recap, because if you're missing something, they will fill in those blanks. And of course, you can always follow up, right? Follow up if you have questions. Dr. Google, not the best option necessarily, right? Maybe ask the real doctor, or nurse practitioner, or nutritionist, or, you know, whoever. Talking with healthcare providers. Okay, 7 things here that I think are important to consider. First of all, again, know your numbers. What's my risk? And all those things that were on the screen, those kind of different pictures that were on the screen. You know, do you have a family history? What is my age? And so on. Those are things that you should be thinking about as well. Do I need tests? You know, when do I need to start getting my cholesterol checked and my blood sugar checked and so on? How often should these be done? These are things you need to ask your healthcare provider. What's normal, what's not normal? When you get the results, they will let you know what's normal, what's not normal. Any lifestyle changes that I can initiate. Again, we talked about a whole slew of things you might be able to initiate. And what support is available? Can I talk to a nutritionist? You know, is there a clinic I can go to? Is there, are there resources, you know, public health resources that I can use? All of these things are really important. And it's interesting because did a lecture for medical students, and as part of their curriculum, they are taught that they should consider these psychosocial factors. And often, just kind of as a quick side note, often we think that, oh, people who don't take their medication, oh, they just don't want to take it. Maybe it's because they can't afford it, right? And so clinicians are being taught now that they should ask these questions, and they should know some resources that they can point people to. So we shouldn't just make assumptions about why somebody's not taking a medication. Maybe they can't afford it because they don't have insurance, or they can't afford it, period. 5 key questions to ask with respect to your medication. So this was a really good info kind of graphic that was created by some organizations. The Canadian Patient Safety Institute, for example, contributed to this. And I think these are really important things to ask, specifically with regard to medications. Because if you're on one medication, you're likely on another. That's just how it is. You know, if you have one risk factor for cardiovascular disease, unfortunately, you probably have another one, right? So we tend not to just have one condition. We tend to have more than one condition. That's unfortunately how our bodies work. Has any medication been added? These are important things. Should medication be added? Should it be changed? Should I continue what I'm on given X, Y, Z? If you're prescribing something else, well, do I need this medication as well? Why it's important to bring your medication to you, or sorry, with you to the appointment. Am I using this properly? Some of these dose schedules, that's the word I was looking for. Oh my goodness, they're very complicated. And if you're on more than one type of medication, it can be really difficult to keep track of. 3 times a day, 2 times a day. Take it at night with food, take it in the morning with food. Like, don't take it with food, take it on an empty stomach. I mean, some of these can be really, really complicated. And what complicates it is if you have that plus another one, ask the questions. Monitor, how are you doing? Do you feel like something's changed if something was added, for example? If you feel like you're off, if you feel like it's not working for you, don't suffer through it. This is why we have a medical care system to assist us with this. And also follow up. Do I need tests, for example, to make sure that this medication is working properly? It's a really good five questions to ask. I'll end it with some key messages. Learning objective 6, not really learning objective so much as just kind of recapping. Starting a conversation. So, start a conversation with somebody. Did you know this? I learned this today. I have some brochures over there, French and English. I have some pins, take a pin. Because there is a need to increase awareness. The low levels of awareness that there are issues really put women at risk. You can volunteer for research studies. So Google can help you out on this. So you can just Google heart disease, not necessarily even heart disease, but you can Google women research participation, TOH, the Ottawa Hospital, University of Ottawa Heart Institute, and so on. And there are databases where you can find out if people are accepting participants. When in doubt, check it out. Don't be embarrassed. Check it out. Get checked out. It doesn't necessarily mean if you feel able enough to have someone drive you to the hospital or get checked out, that's fine. If it's serious enough, call 911. I was doing my CPR training, and the advice was, somebody said, well, how do I know if I need to do chest compressions? And they said, well, if somebody is on the floor, presumably not breathing, and you've tried to arouse them and nothing's happening, and you start doing chest compressions, they will tell you if they don't like it. So just initiate, right? They will tell you if they don't like it. So get checked out. Demand that cardiac issues be ruled out as well. We have to be our own advocates. Again, reiterate, the heart disease is the #1 killer of women. It affects women of all ages, even younger women. Largely preventable. You need to be your own advocate and talk to your healthcare providers. And just to summarize, when women are well and valued, you know, the whole community benefits. So I think that's a really good slide to end on. I'll just, you know, with the last few seconds I have here, talk about some things that you can become involved in. So we're Red Canada. This is why I'm wearing red. February 13th, the day before Valentine's Day, every single year, February 13th. So I'm part of committees that help organize events for this. So you can donate, you can participate directly. There are tons of events all over, not just Ottawa, but all over the country in support of women's heart health, research and initiatives. So really important to check out, just wearredcanada.ca. So pretty easy to get to. There are multilingual resources. I'm part of this committee as well. And so it's really important to get the information in the language of your choice to the best of our ability. So we developed key infographics and brochures that you can download for free in a variety of different languages. In fact, we even have videos with, I think, Quebec and American Sign Language with these key messages. So videos as well as for sign language, of course, and downloadable infographics that are totally free. Just go to wearredcanada.ca. If you know anyone who might benefit from peer support, we have a Canadian Women's Peer Support Heart Hub, womenshearthub.ca. Join a support group. They are lovely. I worked with a lot of women with lived experience, and they are just amazing people. And they're part of these groups. And so, yeah, like this kind of just reiterates, I will send around a kind of thank you email to everyone with some links that you can go to with these resources. So with the top 10 tips and so on, and I'll have links to not only Wear Red Canada. If you'd like to join the Canadian Women's Heart Health Alliance, I believe I put that in the email as well, I'll check. But it's just Canadian Women's Heart Health Alliance. Just Google it, it'll take you to the site. And then if you're interested in joining, you can fill out a form, an application form to join. So that's all I have today, and thank you so much for your attention, and to everyone online that I can't see, but I appreciate you being here as well. But does anyone have any questions or yeah?
I do. So first of all, thank you. Amazing awareness. You gave us a lot of tips. But if you were talking to an employer,
yeah,
what would you say are the top 2 or 3 things we can do to support the women on our team?
Oh my goodness, that is such a great question, first of all. And it's hard because we all kind of have our own individual you know, backgrounds and things that we like to do and things that we don't like to do. But I would say give space for people to talk about it, first of all. That I think is so important. So things like this, I think just amazing that you did. And thanks to Clara for you know, corresponding with me and getting this going. Just amazing. I would say, you know, give space to talk about it. So I don't know. You could say during this lunch period, you know, we're planning on having a session that talks about this. Put some infographics down, right? Or, you know, organizing some sessions where people can actually talk about this. A lot of things that I like to do, and again, this is not possible in all settings and businesses, but a lot of people are starting like walking groups. And so they'll have meetings while they walk around the block. What a beautiful day today, if that's possible to do. So we're going to have our meeting, if possible, not always. Some of the meetings that I do are totally possible. For brainstorming, you can just have a walking meeting, right? And you know, I think for stress management as well, I think all too often, you know, we are afraid to come to our employer, for example, and say, I need to take a day. All these things are going on in my with my family and whatever, I need to take some time off. And there's stigma around that. So just ensuring that people know that it's a safe space, and that, you know, we try not to bring stuff from our personal life here, but it does affect us. And so giving people the space to be able to deal with that, I think is so important. And just being, because, I think we may assume that there's a culture that is kind of, open and supportive of that, but I think that needs to be said directly. So I think that's really important as well. I'm sure I'll come up with a few other things. This is always how it works when I'm thinking and walking. But those I think, are some key things to give people space to do that. And I think, as I mentioned before, stress is such an important thing that we don't think about. And so, in certain workplaces, it can be very, very stressful. And, giving people the space and telling people, yes, we understand that sometimes we need to have some time to refocus.
Sometimes we don't realize we're stressed either.
Absolutely. Absolutely.
It's like, oh, I forgot to breathe the last half hour.
Been there. Absolutely. But I think giving people space to talk about it is really important. And sometimes you can say, well, we have lunches, people talk. No. Say, this is the session we're going to have today. If you want to show up, great. If you don't, and it's kind of like a networking session as well. But unless you designate time to do it, people aren't necessarily going to initiate those conversations. Any other?
Just tips on assessing how your medical person that you happen to be going to is fully aware of women in heart health.
Oh my goodness. That's tough because, as I kind of mentioned throughout the presentation, there are so many different conditions that people don't know about, that general practitioners, for example, don't know about. And it's really a tough thing. So many people, I'll give you an example. So many people people, present to the emergency room, and, young women have a heart attack or present with stroke, whatever it might be. Young women, 35 to 55. They're not asked about whether or not they had hypertension in pregnancy because people aren't making the connection. I mean, I would say bring up the conversation. I attended this women's heart health talk, and I learned X, Y, Z. I'm just wondering if you can give me a little more information about that, like what your knowledge is, or you bring it up kind of thing. We are starting to, and it's actually amazing how much pushback there is. Not pushback as in we don't want to talk about this, but pushback in terms of we just don't have any time in our curriculum to talk about this in medical schools. So the Alliance is making a concerted effort to bring education about women's heart health to medical school curriculum. We started doing this. I believe there's a publication that has been out or is coming out on this. And taking people not only, in doing these particular talks, but actually taking people to medical schools. So cardiologists going to medical schools and saying, hey, did you know, like doing lectures in medical schools, did you know that all of these conditions are female specific and predominant, and you need to be aware of this? Again, unfortunately, I think there is still that knowledge gap. So I think you initiating the conversation and saying, I learned about this, what can I do? What is your knowledge on what I can do as a woman, given my risk factors, and given that I am a woman, what I can do, moving forward about, preventing cardiovascular disease. But it is tough. It is tough because, we think, clinicians are trained in this. No, because again, there's the male model, right? And so we're still evolving in terms of curriculum and our knowledge, but bring it up. That's what I would say. In fact, if a brochure, just take a brochure, I did this, and because these infographics, the links to the infographics are great that medical practitioners can put in their clinics as well. So they can be involved in this as well. And we don't have enough general practitioners in the Alliance. It's mostly cardiologists and internal medicine specialists. So. Well, that's it.
Thank you so much. No questions came in from the chat,
All right.
so
Well, thank you so much for hosting this event. It was a pleasure.
Thank you.
Absolutely, thank you.
No worries.